Hello and bienvenue. My name is Sioban Nelson, and I have the honour of serving as the President of the Academy of Health Sciences. I'm excited to welcome you today to the fourth episode of the Dialogue series. This is a series of informal Academy-led conversations for fellows and non-fellows on a wide range of topics from new frontiers in science to current issues in healthcare. We come together today from right across the country. I would like to recognise that while the Office of the Canadian Academy of Health Sciences is in Ottawa, and as such it is located on unceded and unsurrendered Algonquin and Anishinaabe territory, I am speaking to you today from Toronto, and I'm grateful to live and work on land that for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I pay my respect to the custodians and traditional elders of this land, past, present, and future, and extend that respect to all Indigenous, Inuit, and Métis peoples here today. This dialogue series is an initiative that is part of the Academy's commitment to furthering our understanding of the health sciences, and through this, contribute to increasing trust in science. Please note that the views expressed at all of these dialogues and other Academy events are those of the participants and not of the Academy. I hope you'll be part of our regular audience for these events as we engage with topics of national and global importance in the health sciences. We're pleased to be doing this in partnership with Desjardins. Desjardins is the Academy's bank, and they've graciously provided us with a financial contribution which enables us to keep this series free of charge. But before we begin, a couple of housekeeping notes. We're very happy to provide simultaneous interpretation for this event, and you can choose your preferred language at the bottom of the Zoom window. The chat bar is not active for attendees, but you can all ask your questions by using the Q&A button located at the bottom of the Zoom window. Please submit your questions throughout the session, as we need to make sure that we leave enough time to address them. Now for today's dialogue. The straw that broke the camel's back, health workers during the pandemic. It's my great pleasure to introduce the Canadian Academy of Health Sciences Fellow, Dr. Ivy Bourgeault. Dr. Bourgeault is Director of the Canadian Health Workforce Network and holds a research chair in gender, diversity and the professions at the University of Ottawa. She has garnered an international reputation for her research on the health workforce, particularly from a gender lens. Welcome, Ivy.
Thank you so much, Quay, bonjour, and hello.
Just before we get started on the main topic today of the crisis in the workforce, can you tell us about your research and how it is that you as a sociologist came to be interested in health workforce issues?
Thank you for that question, Sioban, and thank you for the opportunity to present today in this dialogue. So it's an interesting story that you asked, and one in which I was actually asked to reflect upon in a chapter in a book that was edited by my colleague and mentor and another Academy Fellow, Nancy Edwards, on developing a program of research. So I am a sociologist and I've studied health professions since my master's degree. And I saw myself more as a scholar of the sociology of professions and health professions in particular. And it was when the Canadian Institute of Health Research Institute for Health Services and Policy Research launched a mid-career scholars program, which included a chair that was then funded by Health Canada on health human resources. And the scientific director, Colleen Flood, at the time encouraged me to apply. And my response was a bit that I wasn't sure that I really saw myself as a health human resources researcher. I had a Canada Research Chair in comparative health labor policy at the time, and I was examining health worker migration from a sociological lens. But upon Colleen's encouragement, I applied and was successful, and from there have built with many partners an interdisciplinary network, the Canadian Health Workforce Network, as you mentioned, which is really to try to bridge researchers and policy decision makers.
Mm-hmm. And this is a very broad focus, and it's also part of a big international community of researchers. So could you talk a little bit about the networks that exist in this field for people in our audience who are not HHR researchers? And it would be really useful, I think, for people to get a sense of who's involved in these global networks, like which countries do the researchers come from, and what kind of work is happening around the world in the issues to deal with research in HHR.
Absolutely. And so health workforce issues, and I'd like to use the term health workforce more broadly. It's in fact a bit of a Canadian term, health human resources, and I think it gets people to think of this more narrowly around HR issues in healthcare. So it includes that, but it's broader than that. And so because it's a complex field, it does require an interdisciplinary focus, and it requires a partnership between researchers, those who have some lens in terms of policy decisions, whether it's within a health professional organization specific to a profession or specific to a jurisdiction, or within government. So there is a requirement for there to be a lot of dialogue and open communication and joined up approaches and actions going forward. So as I mentioned, we built this community of scholars and decision makers with the Canadian Health Workforce Network. That started in 2011. We had a small contribution agreement from Health Canada. So that makes this our 10th anniversary, which coincidentally is the International Year of Health and Care Workers as declared by the World Health Organization. So every country is involved and is concerned about health workforce, prior to the pandemic and during the pandemic. And the Canadian Health Workforce Network is part of two different communities. So we are a partner in the International Health Workforce Collaborative, which is international in the sense that it includes Canada, the US, UK, Australia, and New Zealand. And that is a group that has been meeting since 1996. We meet every 18 months or so, and we host on a rotating basis, where we share innovative solutions to common health workforce problems, because we have similar problems. Yes, we have unique contexts, and each of the innovations or strategies would need to be not just adopted, but adapted to our unique contexts. We hosted the International Health Workforce Collaborative in 2013, and again in the fall of 2019, which was our last meeting actually, because we haven't met since then. But we absolutely have many important things to discuss. The Canadian Health Workforce Network is also a partner of the Global Health Workforce Network, which is where we're connected to all WHO member states. With the focus on common issues of recruitment, retention, migration, and equity, diversity, inclusion issues. So there is a broader network of which we exist, and we really want to draw on international expertise to approach, again, some of the persistent and wicked problems that we have in the health workforce sector.
So can you give an example of some of the projects or common activities? Are they policy related? Are they empirical? What kind of work happens under the auspices of these collaborative groups?
Absolutely. So there are multiple. And so what we usually do with these, with the events that we hold, is we identify particular themes. So at the conference that we organized in 2019, the particular focus was on equity, diversity, inclusion issues. So how it is that each of these countries were looking at our Indigenous health workforces, how we were supporting Indigenous health workers, and also to ensure that there was cultural safety and humility amongst the different health professions that we were looking at. There was also a focus on scope of practice issues. So how is it that we have a flexible yet safe workforce? Many of the partners that come to these events are in regulatory authorities or those who study regulation. And then there are common persistent problems around burnout, stress, retention, and how that gets reflected. Now, keep in mind, we were studying this prior to the pandemic, and things have only worsened since then. So many of the crises that we see now have roots prior to the pandemic. It wasn't a level playing field to start with. And so, and then issues of migration, because from an international health workforce collaborative perspective, these are some of the destination countries, for the lack of a better term, very high percentage of internationally educated health workers in these jurisdictions, and also persistent problems in integrating workers from different jurisdictions into our different countries. And so really sharing resources on those topics.
And those resources then go to policymakers, to whom? How does that work?
Yeah, so the events have been open, and we try to make sure that there is a rich variety of people participating. So these are not research conferences. There are researchers there. There are those in health professional organizations, be they, focused on training and preparation of the health workforce, those in regulatory authorities, those in accreditation bodies. Because there are a variety of different health workforce stakeholders that can make decisions, as well as those in regional, provincial, territorial, federal governments. And so depending on the jurisdiction where many of these activities take place, so just reflecting on the last conference, we had folks from the Commonwealth government in Australia present on a health workforce data dashboard that they created, the Heads Up tool, which was based on standardized health workforce data that AHPRA, which is their health regulatory agency, collects for 14 different professions. And so they were able to display that. We typically hold a pre-conference data Olympics where we talk about common data challenges and different ways that we approach it. So there's a lot of sharing of approaches and figuring out how we can adopt that in our respective countries.
Mm-hmm. Mm-hmm. Thank you. So we'll get to the pandemic and the tipping point issue in a moment, but first you alluded to the fact that this last conference was in 2019. I think it's important or helpful for us to distinguish between where we are now and where we were heading before the pandemic hit. So can you talk a little bit about, if you take us back 2 years, what was the state of the health workforce and health workforce science in Canada at the time? So can you give us a bit of a baseline, for want of a better term? And if there's anything that you could share about the provincial level or the differences among the professions, how good a picture do we have of where we were when we entered the pandemic, or the pandemic entered us, is probably a better way of thinking of it.
Indeed. Well, so I'll reflect on the International Health Workforce Collaborative meeting that we hosted in the fall of 2019, and around about that time, colleagues at the Canadian Health Workforce Network wrote an op-ed in the Canadian Medical Association Journal. And this is something that we were invited to write, coming out of a panel from the, the Canadian Association of Health Services and Policy Research. And the op-ed is titled, "Poor Health Workforce Planning is Costly, Risky, and Inequitable." Now, just to allay any concerns, we didn't predict the pandemic in this op-ed, but let me go through each of those three parts in turn. It's costly. So when I reflect on when the International Health Workforce Collaborative started in the fall of 1996, Canada was actually sort of well ahead in terms of having a good cadre of health workforce scientists, good data, good conversations between health workforce decision makers and health workforce researchers. And between 1996 and 2019, we seem to have lost our way. And so we've really fallen far behind our comparative countries in the International Health Workforce Collaborative, as well as in the Global Health Workforce Network. very, very far behind countries like the Netherlands, for example, in terms of their approach to health workforce data. So first of all, how it's costly. It's important to note that the health workforce is the bulk of the health system, right? Most of the costs of the health system are related to the health workforce. Estimates of about 70% of the costs of the system are the workers in the system. It's a labor-intensive field. It's costly in the sense that health workers constitute 8% of GDP. That doesn't include the cost of training, the training that health workers personally put into their time and their funds, and how we as a public subsidize health worker training programs publicly. So it's even more than 8% GDP. And yet we collect very poor data on this. And to compare it with other jurisdictions or other sectors, I should say, the construction sector, which constitutes 7% of GDP, there is an organization called BuildForce that collects really good data. They do a lot of planning around 30 different professions and trades, construction. We don't have anything like that. Other countries have health workforce agencies or observatories where they collect data, particularly for planning purposes. So if we look at, for example, medicine, we were asked to do this commentary in the Canadian Medical Association Journal. We have a for-profit Scott's Medical Directory, which is a directory to sell things to physicians. That directory is purchased and some updates are made to it to make it a database, but it's not a database for health workforce planning purposes. For nurses, we get data from the nursing regulatory authorities, and they're very disparate across the regions. So it's very costly to have all of these organizations collect data that are not standardized, not fit for planning purposes. So that's costly. That poses risks. This is the risky part, because we aren't able to plan. You want to have, what we would call sort of an early warning system to say, oh, it looks like we are seeing lots of retirements in this sector, or that we're not seeing, we are seeing high vacancies in this sector. We're seeing lots of attrition, in educational programs in this sector. We want to be able to know what's happening, because otherwise everything is a crisis and it's all downstream, rather than thinking upstream about how we could prevent some of these things. And the third part is that it's inequitable in the sense that we barely have good data on gender, and it's usually as a binary, male or female. We have no data on the racialization of health workers. We have no data on the Indigenous identity of health workers. Zero, none. We don't have any data on disability. We have very poor data on the ability to provide services in the official languages. It's remarkable, egregious really, about the lack. And so these were things that we talked about before then. So that's the state of data and planning. So poor planning based on poor data, that is siloed by jurisdiction or by profession. And prior to the pandemic, that's on a planning level. On a workforce level, we had endemic rates of violence against health workers to the point that it was almost invisible, despite the fact that there were many reports being written, but no one was talking about it or thinking about it. And so there are quality of work life issues that predated the pandemic. There were poor data quality issues, poor planning issues that predated the pandemic. And so it meant that we were caught, really with our pants down when the pandemic hit, and everybody was scrambling. And I can't imagine what it must be like to be in a decision-making role, to have to make decisions completely in the dark without there being any evidence or guidance. That must be a very, very unpleasant, stressful place to be in.
Absolutely. So before we began the pandemic, we were certainly in Ontario in the middle of the hallway medicine crisis, so things were not good. But the current crisis is all about health workforce burnout and shortage. It's absolutely all over the media. It's being said that COVID turned a crack into a crevice. I read that somewhere, and I think it's a good description. It seems that every day in the media, you read yet another story about burnout and attrition, or the overwhelming pressures that are on the system through the backlog. Just this past week, we have a new piece that was on the US situation that was by Ed Jong in the Atlantic, which is very hard to read. And the UK is struggling from the impact of the exodus of all the European passport holders from the system on top with Brexit, on top of everything else. And there are similar stories that are coming out around the world. And WHO estimated 18 million health worker shortfall by 2030. So can we begin with the global situation again and talk a little bit about why this is a global story, when we know the pandemic is a global story, but the crisis in health, human resources, health workers, supply is, as with the situation you just described in Canada, is a crisis on top of a crisis. So what is the state of the global workforce and the issues that we have around building sustainable supply around the world? That important? Why is that important for Canadians to know about?
Absolutely. That's a really important question, because we have to always recognize that we exist within a global context. And to also put the shortfall of 18 million, that was prior to the pandemic. Those were projections prior to the pandemic. I haven't seen the new projections because I think it's a moving target. Utilize whatever analogy that you want to do. This is a snowball, right? Because the more people that leave, the more people that are likely to leave, because it leaves an unsustainable situation. So something has to be done quite urgently about this, and it needs a bold response. And I know we'll get to that momentarily. To put things into a global context, 2006, the World Health Organization dedicated its World Health Report to the health workforce, to that topic. And that was to launch what was to be known as the Decade of Human Resources and Health. This is the way that the WHO refers to it: human resources in health, human resources for health, to take that kind of broader social determinants of health perspective. So from 2006 to 2016, there were to be remarkable improvements in health workforce data and recruitment, retention, planning, etc. That in Canada was a lost decade. There was really nothing to show for that. Well, very little, can't say nothing. So that's to put that into context. In 2010, the WHO, with a lot of discussions with all countries, but really propelled by low and middle income countries that were feeling they were being rated for their health workforce, and wanted there to be some type of recourse to that. So there was the development of a voluntary code on the international recruitment of health professionals in 2010. We were doing research around that time, and it was remarkable how few decision makers in various roles in Canada were even aware of the code. And we had signed on to it. And it's a voluntary code, but it is, it establishes a set of values, a set of principles that we should be focusing on. One of the core principles is self-sufficiency. We should be able to, staff our health workforce with our own folks. So again, it's not to say that people shouldn't be able to migrate, and if they've migrated, that they should be integrated at the very best that they can. So there were statements in the code to look at those issues. However, there seemed to be less attention to the types of data infrastructure that we needed, the decision-making tools based on that data in order for there to be better planning, better staffing of the system, and therefore better work life. You know, around the same time was this whole kind of implementation of very lean management strategies in different health workforce organizations. Lean, capital L or small l, you know, happen to be the same thing. There was a system that was sort of a just-in-time system. There was no backup, and that is unsustainable in a steady state. So we had high rates of burnout and presenteeism and distress in the workforce prior to the pandemic. Then there's this immediate surge and this emergency crisis, and people, some folks in the health workforce being recognized as needing personal protective equipment and others not, and feeling like, well, why am I not recognized as needing this? So there was a whole sense of that. And then I think most of the responses were very much focused on an urgent response rather than a long-term response. I think people can reflect on, our whole point was to flatten the curve, right? To keep the demand under what was capacity. And capacity was often pictured as a flat line. Well, capacity isn't a flat line, right? The capacity could go up, it could go down. And also when we planked the curve, as they said, it made the pandemic much, much longer. And so this was a longer type of response strategy, and there wasn't appropriate recognition of that in terms of how we needed to give people some time off for there to be some circulation. But we just didn't have enough staff because we had always been working on a very, very lean approach.
So there was no capacity in the system to actually stage and protect people at the time. So let's talk about Canada now. The president of the CMA, Dr. Catherine Smart, is quoted as saying, and in fact, I saw something today in Hospital News where she says it again, is that we simply don't know how bad the doctor shortage is in Canada or how to fix it. The Science Advice Table in Ontario recently reported a study where 60% of health workers reported emotional exhaustion. The CFNU, the Canadian Federation of Nurses Union, cites 16,000 nursing vacancies across the country. Another union, the SEIU, reported an 18 to 20% vacancy rate for nurses last month, this past October. In fact, vacancies in nursing are said to have increased some 78% from pre-pandemic levels in just 2 years, which is the largest increase in any sector in the labour market. And overall, job vacancies in healthcare have risen some 40% since February. Now, I throw these numbers around with a little pinch of salt, because anyone working in the sector knows that vacancies can be a rubbery figure, particularly nursing vacancies. And many of the sources one finds are actually media pieces on this for the reasons that you outlined. So that means there's a lot of mixing and matching of data sources. So we have to be a little bit careful on it. But even with that caveat, the numbers are huge. And we don't hear, I've certainly not heard anyone saying there's not a problem. So we also have multiple surveys on intention to remain. The RNAO, the Registered Nurse Association of Ontario, reported that 15% of nurses who they surveyed were considering leaving. And I think it was in the Ed Yong piece in The Atlantic, he quoted the US Critical Care Nurses Association, and that's a sector that's been very hard hit by the pandemic. They reported that 60% of those nurses have thought about quitting the profession. So what's happening here? Let's talk about how big this problem actually is.
Yeah, thank you. And all of those statistics are really quite sobering. They paint a very bleak picture. I do want to state at the outset that there are solutions. So we want to make sure that we can highlight that. So it is a crisis. It's a retention crisis. I think it reflects a broader issue that they call, for example, the Great Resignation in the United States. So the health workforce is part of that trend. So there are trends, but there are very unique circumstances within the health workforce. It is a crisis like we have never witnessed before. And yes, there are a variety of different data points. But if you look at the StatsCan data, looking at vacancies from Q1, and they just released them earlier this week for Q2, are even higher. So the data that you quoted from the CFNU was from the Q1 StatsCan release. And those are data that we can trust, recognizing that, yes, as you say, vacancy rates are rubbery. There are so many studies, looking at rates of burnout, presenteeism, intention to quit. So we have a project within the Canadian Health Workforce Network, the Healthy Professional Worker Initiative, and we have very, very high rates of burnout, presenteeism, intention to quit. And the intention to quit is particularly high amongst nurses, midwives, and physicians. We didn't survey every single health worker group, but these were groups that were particularly high. So it is not a crisis of just one jurisdiction. It's not a crisis of just one health profession. It's in nursing and medicine and personal support work, midwifery, dentistry, pharmacy, a whole host of professions. There's a whole host of mental health and substance use health professions, of which we don't count whatsoever, with the exception of very basic data on psychology and social work and occupational therapy. And they are having a huge capacity to respond to the growing needs in substance use, in mental health that we are seeing, the shadow pandemic that we talk about. And today has launched, the 16 days of action of violence against women. So for each profession, it predates the pandemic, and it reflects their different circumstances. When you talk about hallway medicine, that is a health workforce issue. When you talk about wait times, that's a health workforce issue, right? And just the frustration that workers have about being able to do a particular job because they're waiting on another group. I mean, we did interviews with dentists in Quebec that were really particularly worried about the shortage of dental hygienists that were having an impact on their jobs. So this is an interprofessional issue. It's not just what's happening with one profession. So you have to take a whole of systems approach, or at the very least, a sector focused approach. Older adult care, particularly problematic. Mental health and substance use health care, particularly problematic. And so we need to take a sector focus on this. So some of these professions and jurisdictions we know something about, and some we know very, very little about. Again, some people we don't even count. There are only a few jurisdictions that count personal support workers, and that's just counting. That's not sort of figuring how much people are working, or are you working, and then how old you are, and what place you're working, where you are available, because it isn't just about head counts that we need. We need much more robust data. So the source of this problem is an incredible inadequacy of our health workforce data, which we talked about in our op-ed, and we've been writing op-eds since then, and sometimes media focus on these issues. Andre Picard focused on these issues, and it's remarkable how it doesn't seem to get traction until now. So it's a crisis. And again, there are solutions. They are not going to be short-term solutions.
So let's talk about some of those. So let's talk about solutions. Yeah. I mean, the initial response is usually to throw money at a problem. And we've seen some of that recently. I mean, I think, was it just this week that in the US, Kamala Harris announced a $1.5 billion investment for underserved communities, to provide health workers for underserved communities. And And there's been some initiatives in Quebec and in other parts of the country, and also some focused initiatives in areas such as long-term care and so on. So where does money fit into some of these solutions, if you could? And let's talk a bit more broadly around what does work, what has been shown to work, given the very challenging circumstances globally that we're facing.
Yeah, absolutely. And it is a problem that will require funds. It will require some money. I do get worried when people say throwing money at a solution. It needs to be very targeted and very focused. And it's important to understand what the counterfactual is, that it's very costly for us not to plan. It's very costly for us not to have good evidence. So the counterfactual is even more costly than the investments. And so we want to make smart investments. And with any complex problem, it requires a multiple intervention strategy, and it really requires coordination. So we have, many organizations have signed on to a call to action to have greater coordination and federal government leadership in that initiative, and to very much recognize that the federal government has a role to play vis-a-vis the provinces and territories as well. So I think for this immediate concern and crisis that we have, it would be very important to have evidence and shared strategies, to curate the best evidence and shared strategies around responding to this massive exodus that we're seeing. What works, what doesn't work, what should we be focusing on? And this is something that a coordinated health workforce agency can do and has been doing internationally in countries that have some type of coordinated agency or observatory, is really curating the best evidence and sharing strategies, conducting very rapid applied research and policy analysis to inform those strategies around retention. We also need some upstream strategies around collecting much better standardized data across the health workforce so that we can develop much better plans that will enable us to have these early warning systems so that we could have and develop partnerships to mobilize around policy coordination and policy response. So coordination, evidence-informed strategies, and really building capacity in those people who could provide much greater guidance and expertise and evidence for decision makers so that they're not making decisions in the dark, that they're making the best decisions. And, you know, is this going to solve all problems? No. We'll need to course correct, absolutely. And this is a learning health system, but let's make it a learning health system based on the best data and evidence that we can pull together. So those would be some elements of a solution space.
So you've talked about a solution as a sort of the structural solution. So there is evidence. How do we bring that together? How do we build strategies on that? How do we share? How do we have policymakers involved? What systems will support that? Do you have examples of specific types of interventions that have been shown to work in other jurisdictions or in Canada with certain populations and groups? Can you flesh out what we're talking about? I mean, I know we're talking about getting all the evidence into a structure that enables policymakers and decision makers and recruiters to plan for a better system. But I think people would also be interested in actually specific initiatives. What sort of things have been shown to work? Not to fix everything. Clearly, this is a multifactorial, long-term issue, but some examples I think would be good to see.
Yeah, absolutely. And it's important to recognize, yes, it's complex. It has multiple layers, but, you know, we do eat an apple one bite at a time. And so it's important to kind of take Take this a bite at a time. I think about it, from a very Donna Beattian framework, that there are structures. These structures have particular processes, and that we have a particular outcome in mind. And the quadruple aim should be the outcome that we have in mind, which, sometimes people forget that the fourth aim is about the health workforce. So that's really important to make sure that we have all of those things. So it's not just a structure for structure's sake, that this structure is to be doing certain things, processes around partnerships and mobilizing knowledge, curating evidence, conducting applied research, developing these early warning systems. And so there's a variety of different layers. And it's important that this structure, process, and outcome is not just about planning. Planning is part of it, but there is supportive policies and programs and services and important management strategies. So what has been really sobering to be occupying this space, and I'll reflect on a rapid review that we did, commissioned by what was then the Canadian Foundation for Healthcare Improvement, now Healthcare Excellence Canada, to look at the strategies in response to the pandemic and how we could curate that into a database. And so we did two things. We curated what people were doing around COVID, and then we also looked backwards. What was done and what worked for other disasters and pandemics? So we looked at SARS and H1N1 and Ebola. We looked at, particular emergencies around hurricanes and, sort of natural events. And what was sobering is that there was a lot of commentary about here's what we did and here's what we should have done. There was very little evaluation. Mm-hmm. And so it's really problematic. And we haven't updated it because there has simply been an explosion of literature of different strategies that have been used during the pandemic. But we're very, very worried that there has not been a parallel evaluative component. And this speaks to the importance of very targeted scientific approaches. Really, health workforce science has generally been underfunded. I mean, in a review that they did for health services and policy research, right? Less than 3% of health services and policy research goes to health workforce research. Which means that less than 1%, in the range of 0.7 or less of CIHR funds goes towards health workforce research. And, I'll remind you again, 70% of the cost of the health system are the health workers. Am I saying that 70% of the funds at CIHR should go to the health workforce? No, we absolutely have no capacity for anybody to take that on. But should it be more than, less than 1%? Absolutely. Absolutely. So there is this absence of evaluation of what works. There's an absence of data. And so this is a really toxic cocktail for the health workforce.
So one of the things that you did talk about and just mentioned earlier, and I've heard you speak about before, and I'll just remind people, if you have questions, please pop them in now. From the RNAO, they have corrected my use of their figures. Thank you very much. They've just said that they found that 40% of nurses in their survey were somewhat likely to leave. And from Laura Ziknia on the Canadian Association of Medical Radiology Technologists, there's discussion of the mental health crisis, and we'll come to that in a moment. Thank you. But please post in any questions that you have. You just touched on the issue of sector planning. So could you talk about that as an approach? Talk about mental health or mental health services, mental health and addiction services, or perhaps the area of cancer oncology. What does sector planning mean, and why could that be a solution to our highly balkanized, siloed approach, just-in-time approach to planning?
Yeah, absolutely. And I think that we could take a page out of within Canada with the cancer sector. So they look at a cancer sector approach. That's the way that they do that. So the leading practices internationally are to, for example, in New Zealand, in the United States recently, is to plan by sector and to recognize that there is an interprofessional team, that every member of the team brings their expertise to a particular issue. In cancer care, they found that many of the sources of the delays and the wait times were because of the insufficient numbers of medical radiation technologists. So to speak to Laura's point, right? Also the issue of, how long it was taking for tests to get done around the pandemic testing as a shortage of medical laboratory technologists, right? So these are often invisible roles. Like when we think of health workers.
If I could interrupt you for a moment, because Christine Nielsen just posted that the Canadian Society for Medical Laboratory Science had just confirmed that 42% of the workforce is looking to change jobs next year. So I just think that's a salient footnote to your comment. Yes.
Yeah. And so we work with the folks at the Canadian Association of Medical Radiation Technology and with Christine and the CSMLS. And it's important to look at all of these different professions and sectors. And so one profession can exist across multiple sectors like nursing and medicine, and then some professions are specific to a sector. And so we would want to make sure that we are gathering data and planning with that approach in mind. So for example, released just earlier this fall, the Health Research and Services Administration of the federal government of the United States released a sector-focused dashboard, and they focus on some particular sectors. Behavioral health is what they refer to as their mental health and substance use health sector, women's health, primary care, long-term care, which is their short form for older adult care because it includes home, community, and long-term care. And so they developed this very interesting dashboard, which includes standardized data across a range of health workers. So just in behavioral health is about 12 different workers, and it doesn't capture all of them, but it captures more than we capture here. And it's important to look at all of those professions together, because it's not just about making adjustments in terms of maybe we could increase enrollments, in educational and training programs. Maybe we could adopt certain health workforce strategies to delay retirement. So those are numbers focused, but how it is that we task shift or share tasks, overlapping scope, and the work that we did earlier with the Canadian Academy of Health Sciences on scopes of practice. There's really important strategies that can be adopted there if we take a sector focused approach. So yeah, that would be one leading practice to adopt that way. But also people have to recognize that planning and management and health workforce science, health workforce planning policy is not a one-off. It isn't just oh my God, we have to respond to this crisis. It is such an important resource in our health system, the health workforce, that this needs to be a cyclical process. We need to constantly be doing this and updating it as the data improve moving forward, because the more data points that we have in the past, the better able we are going to be able to project forward in terms of what's happening and develop those early warning systems. So that's where we should be headed.
Thank you. Thank you. We have a couple of questions. I'll just take them now, if that's okay. So Medi Army, thank you for your question. They have asked that thanks for all these important points. There's no question that the data is insufficient to understand the health workforce in Canada. What I wonder is that you have in mind a federal structure that would also contribute to decision making, say a Canadian Health Workforce Agency, in addition to the data effort.
Yes, absolutely. So we are encouraging the federal government to take on more of a leadership coordinating role respecting jurisdiction. So we're not asking the federal government to do health workforce planning. We are asking the federal government to invest strategically in the collection of much better data on the health workforce, adopting a minimum data standard for all professions that could adopt across stakeholder organizations, from the regulatory authorities, so when health workers register, or professional associations that represent the interests of professions, and hospitals and other healthcare facilities that staff different health professions. If everybody was collecting data in the same way that could be joined up and moving things forward, yes, that is absolutely something that the federal government could do. The federal government has a role to play in terms of data through Statistics Canada or the Canadian Institute of Health Information. Absolutely, but that's just one potential role that a coordinating agency or organization or observatory, as they say, a rose named with any other name would smell as sweet. I really don't care what name it's called, but that it takes on these functions of a health workforce observatory or agency, collecting the data, curating the evidence, sharing it, really bringing together different stakeholders to develop the best knowledge that we could in this area, and getting to those early warning systems and building capacity, because there just aren't enough people doing this type of work.
No. We have another question, which is to do with the regulatory context. Fred Enns, thank you, Fred, says, fascinating topic. Would you comment on the current regulatory context in Canada and how this discombobulation, many would agree with you on that, impacts human resource planning in the health sector?
Yeah, absolutely. Thanks so much for that question, Fred. So we do have a federated system where health professional regulation is the jurisdiction of provinces and territories. I think that there's a way that there can be agreement from the provincial and territorial regulatory authorities to have centralized data collection for registration purposes. Again, regulation would still happen in the jurisdiction, but registration could be joined up. And some professions are moving in that regard. So physiotherapy is really quite a leader in that regard of having joined up. And in nursing and medicine, there are structures in place that could easily be adopted so that we could have pan-Canadian registration data that the regulators have. And that would be data that would not just be for health workforce planning purposes, but data that would be really important around health workforce management and, staffing and work life, and getting much better standardized data around, burnout, presenteeism, intention to quit, as well as really good data that the regulators need to share data on discipline and complaints across jurisdiction. Yeah. That, again, is another risky part of not having joined up data, is that there may be somebody practicing in one jurisdiction moves into another, and there hasn't been sharing of that information, which was the impetus actually in Australia for them to move to a joined up system of regulation. But we can get to a system of registration without there being any changes in the regulation and the approach to regulation. There can be agreement by across jurisdictions, profession by profession, to agree to a pan-Canadian system of registration. Where there is not regulation of health workers, such as in the case of many mental health and substance use health workers, personal support workers, there can be a national licensure or registration system where we could utilize the best minimum data standard to collect data on those workers for planning purposes, but also, for patient safety purposes.
Thank you. And so we also have one question from Sophie Miles, who is asking a little bit more on what you just were talking about how can regulators, decision makers, etc., better address the needs and lived experiences of our healthcare workers when providing their invaluable work. Yes. So how do we support I think this is a question about the support for mental health workers.
Yeah, absolutely. And so recognizing that there are lots of studies of health worker burnout and stress and distress and presenteeism without a lot of really good evaluation of interventions. There have been many interventions that have been developed during the pandemic. And I will say many of those are individually focused on what the health worker can do. That's important, but I also would want to recognize, caution that much of what is impacting health worker burnout is not within the control of health workers themselves. So we need to have intervention strategies on health worker burnout that includes the individual, but focuses also on the team, the organizational, and the system level. So we need sort of, again, multi-layered interventions. And which interventions work for professions in which particular circumstances. So again, a sector focus is really important. And a career course focus is really important. Something may be quite necessary for health workers who also have lots of family responsibilities. We want to take an intersectional gender lens that recognizes this may be very different if you are a young woman in an Indigenous community versus an older racialized man. So you want to look at those different cohorts, early, mid, and later career. What's going to keep people in a profession? Because what we were finding, again, pre-pandemic, is that there were two places that were a particular loss: older workers and early career workers who would, get enough to pay off their student loans and move to some other job.
Yeah.
And so any type of strategy would need to have that a different type of approach. There's not going to be one solution. It will be multiple solutions that need to be adjusted.
Thank you for that. So I think final question. I want to put some history in here. Our healthcare systems have suffered major crises in the past, usually following extraordinary shifts in the system. So post-World War I, with the construction of all the veterans hospitals and the establishment of the rehabilitation sector, there were drastic shortages of nursing and medical personnel. And that was followed by unemployment in the 20s and 30s and so on. And after the creation of the national health systems, such as the NHS in the UK in the post-war period and other public systems in subsequent decades in countries such as Canada, there were incredible staffing shortages as the system expanded to a population level service. So right now we're facing significant challenges in the current staffing model and a daunting backlog of services that we've discussed resulting from the pandemic. My question is this another moment for transformation, not just fixing the system? Will we be looking back on this period in a decade or so as the end of one era and the beginning of another in terms of how the system serves Canadians and how health workers practice within it?
Absolutely. And I think that we're at a point where we should be very bold. No small change, because we are 20 years behind. And so we need to make not an incremental change, again, recognizing that we eat an apple one bite at a time, but we should have a very, very forward-thinking goal. This is going to take a long-term investment. Absolutely. In our call to action, we were suggesting a 10-year investment, building up, because we're not going to solve this with a big, huge investment right now, but it needs to be an investment over time so that there's some sustainability. And so my hope is that when we look back on this in 10 years, we will have made remarkable improvements. It is doable. This is an area which really meets science and innovation, digital technology. Let's build on these various investments that and highlighted areas of investment and really, really move this forward. So that is my hope. And so thank you for offering to take that historical perspective.
Thank you. And a great note to close on. Thank you so much, Ivy, for this really informative and important discussion. And thank you everybody for tuning in and for your questions. This is the final dialogue of 2021. We'll be back in January with the next series of talks, and scheduling information and topics will be made available soon. So thank you everyone for joining us today.